exciting episode of Mid-Synapse podcast series. I'm your host Hetvi Shah, and today we are diving into a critical topic that often goes undiagnosed and is often under the radar: sleep apnea beyond obesity. So, when we think of sleep apnea, the common perception is that it usually affects obese or overweight individuals. But recent studies reveal that even non-obese patients are at significant risk, often going undiagnosed. And to help us decode these complexities, we have with us Dr. Swapnil Deshmukh, who is a leading expert in pulmonology and sleep medicine. Dr. Swapnil is a renowned pulmonologist with extensive expertise in respiratory diseases, sleep disorders, and critical care. He's been at the forefront of diagnosing and managing sleep apnea, especially in challenging cases where conventional risk factors don't always apply. With a deep understanding of emergency diagnostic tools and disciplinary care approaches, he's here to help us uncover the hidden risks of sleep apnea in non-obese patients. So welcome, Doctor. It is such a pleasure to have you here.
Thank you so much, Hetvi. First of all, thank you so much for having me here, and thank you again for such a warm welcome. I would like to congratulate you first to select this topic. As you mentioned, it is a very burning topic, and the disease is very much underdiagnosed. And the thing which we are seeing right now is just a tip of iceberg. So basically, there is so much more to obstructive sleep apnea and sleep-related disorders than which is known to us right now. So I would like to congratulate for bringing up this topic, and it would be nice to discuss about the same.
Yeah. So, Doctor, before we dive deep into the topic, could you just tell me more about your professional journey and what actually interested you in pulmonology?
So I did my MBBS from Indira Gandhi Government Medical College, Nagpur, and then I did my specialization MD in respiratory medicine from MS Ramaiah Medical College, and I got my specialization degree from Rajiv Gandhi University of Health Sciences, Karnataka. Then I also completed my DNB from the National Board of Education, and I had been working as a pulmonologist and critical care specialist in a few hospitals. First, I worked in Bangalore in a couple of hospitals, Sanjeevani and Pod Road. After completion of my course there, I switched to Mumbai, where I worked in Gleneagles, or now Global Hospital. And now, since last 1.5 years, I have been working in Pune. I am working as a consultant pulmonologist in DY Patil Medical College and Hospital. And as a pulmonologist and critical care specialist, I am associated with Ruby Hall, Hinjewadi. So what got my interest into respiratory medicine and sleep medicine is that first of all, I always had a fascination about medicine and the related branches. So medicine, respiratory medicine were my topmost priorities during my specialization. It has mixture of all. It has mixture of conservative management. There are interventions. There are some other disorders like now sleep medicine, which is upcoming branch. So it keeps us on the toes while we are treating the patient. So I like this branch in that way, and it always gives you some new challenges. So that keeps your day interesting every day.
Yeah. Thank you for sharing that inspiring journey with us. Okay, so now let's dive straight into our topic. So sleep apnea in non-obese patient is often overlooked. So why is that, and actually what are the biggest diagnostic spots that doctors need to be aware of?
Very interesting question. So first I will just brief you about the epidemiology, if I can, about the sleep apnea and related disorders, especially in Indian scenario. So if I talk about last few decades, now the awareness has been increasing about sleep and sleep related breathing disorders. However, if we compare to the Western world and other countries, it is still being largely underdiagnosed. So the problem is grossly unnoticed, not only from the patient's point of view, but also from the clinician's point of view. If we talk about the clinician's point of view, many times they have a stereotypic image about the patient, that patient will be a male who is obese, with having short neck, and maybe history of hypertension and cardiac disorders, and then only they will suspect OSA or obstructive sleep apnea, and then they further will screen that those patients. However, now there are many other recent studies which has clearly showed that it is not the stereotypic form of the patient that those will suffer from the OSA obstructive sleep apnea, but even young patients or patients belonging to other gender, that is female patients, are often being diagnosed with OSAs, that too severe OSAs. So, as a clinician, you must be vigilant about the other stereotypes or other phenotypes of obstructive sleep apnea. Now, I would like to quote a recent study which was published in 2 to 3 years back. So, it was a systematic review of various patients in India. So, what it suggested is that the prevalence of OSA may range from 9% to 38%. So, different studies have quoted different percentage. Why? Because many epidemiological parts there is not proper diagnosis of OSA being reached in different parts of the countries. And earlier it was quoted that around 13% of the patients who are diagnosed are male and around 5 to 7% are only females. But now we are seeing in our clinical practice rapidly the number is increasing in terms of females. One reason is also contributory that female obesity is also increasing largely in Indian subset of population. However, non-obese male patients are also being seen recently in our clinical practice of having OSA, that too moderate to severe OSA. So, as a clinician, as a pulmonologist or a sleep medicine specialist, we must be very much vigilant and aware about these other factors. Obesity, having a male gender or hypertension are, yes, they are definitely a risk factors. Even definitely the different screening tools like stop bang and ESS, they also give weightage to all these risk factors for diagnosing or screening the OSA. But that doesn't mean that other patients may not have OSA. So we need to keep our eyes open about this as a clinician. In terms of patients also, I would like to say that many patients are still not acknowledging the problem that they are having something, they are having some issue or something like OSA exists. So there is definitely lack of awareness. And from national point of view, there are many policies from government about non-communicable diseases like obesity, hypertension, diabetes, etc. But there is still not concrete policies, or there are no policymakers who have formulated any guidelines specifically for OSA. So this topic has been neglected. But however, now it is upcoming and many people and clinicians are getting aware about it. So I hope that we will diagnose more and more cases and treat more and more cases and prevent the complication.
Yeah, absolutely. That is actually rightly mentioned by you. So now, doctor, now when it comes to actually diagnosing OSA, we usually hear about home-based sleep studies versus lab-based polysomnography. So from your experience, which one is more effective?
So as a clinician, as a sleep medicine specialist, I will definitely recommend a gold standard test, that is level 1 polysomnography. So a sleep study, also called as polysomnography, has different levels of strength, so to say. So if I go ahead with the topmost level of polysomnography, it is done in the lab, where a proper sleep technician is also accompanying with the patient. He also has to be there entire night with the patient. And we not only check certain parameters like drop in the saturation or the respiratory rate or the movement of the chest, but there are other electrodes or other parameters also which check brain waves, so to say, the movement of the chest, the movement of the muscle. There are electrodes over the chin. There are they also monitor the type of sleep that you are in, whether you are in rapid eye movement type of sleep, N1, N2. There are different stages of sleep. So in this proper polysomnography, all these steps are monitored, and accordingly the diagnosis of sleep apnea is made. So that is the gold standard. So as a clinician, as a sleep medicine specialist, I will definitely recommend level 1 polysomnography to all the patients. However, nobody wants to just get hospitalized for a sleep study, or nobody wants to stay in the sleep lab. So the patient compliance is very much poor in terms of this level 1 polysomnographies. And of course, right now the cost is also slightly higher compared to the home-based sleep study. So now there are different home-based sleep studies which have come, that they allow you to sleep in your home, and they put the appliances over your body, and then they check the different parameters. However, as the sleep technician is not there, there is not adequate monitoring about the sleep hygiene and everything. This level is not up to the mark to the first one which I said. That is why if we want to diagnose the OSA properly and 100% confirmly, then definitely sleep lab study is definitely better. However, those patients, rather than not diagnosing, if there is an option given to me, I would also recommend home-based sleep study to such patients, because at least I will get an idea that patient is having some component of OSA, though I may not be confirmly sure. Then later on I can recommend the patient that you need level 1 polysomnography. So sleep study the home-based sleep study definitely has a role, especially those who are very resistant patients, those who are not willing to get hospitalized or don't want to spend the money. So, but however, it cannot replace the level 1 polysomnography.
So, doctor, you also mentioned that it is often overlooked. So, how often these diagnosis tests are actually used also?
Nowadays, sleep studies are happening quite frequently. If I go ahead during my training days or something, then I hardly heard that there are so frequently sleep studies happening, polysomnography happening in most of the hospitals and medical colleges. Now, even in the most of the corporate and tertiary care centers, sleep study is happening. Earlier, those facilities were also not available in most of the tertiary care centers. So now the frequency of sleep studies have increased a lot. So if we talk about my organizations, we definitely have our calendars is already blocked for the month of sleep study, and we have to give the appointments for the next couple of months, because our it requires a lab, and lab cannot be given to more than two patients at a one time. So according to the bed availability, we have to give that occupancy. So I am saying basically that at least 3 to 4 sleep studies are happening every week in our organizations, at least in one organization if I am comparing. And accordingly, now the second part of the sleep study is that once it is diagnosed, we again have to admit the patient sometimes for titration of the medication. Basically, CPAP is the treatment of choice. So to titrate the pressures and everything, again we may have to do sometimes CPAP titration study for such patient. So that again requires another night many times. Sometimes there is a split study option also there, where we do both in a single setting. So that also is based on patient to patient and everything. So now, because of these types of studies, it is happening more frequently. As I said, at least 3 to 4 times in a week we are doing that, and we are also diagnosing more and more cases of OSAs in that term.
Now, doctor, let's talk something about advancement. So, AI wearable devices are popping up everywhere. So, can we actually trust them for sleep apnea?
Right, and very important and interesting question. So trust is the one important word that you mentioned in your question. So the straightforward answer will be no, because right now we don't have validated AI wearable tools which can confirmly tell us that this is the apnea hypopnea index of this particular patient, this is the sleep pattern and everything. Though they are claiming everything, but it has not been validated. So validated means most of the AI wearables, they are claiming that they are checking at least 4 to 5 parameters in their appliances, which are like around more than that in level 1 polysomnography. So if those parameters which they are checking are being validated and it is matching based on the level 1 polysomnography, and it is being published in reputed journals, then we can actually trust these wearable devices. However, this is very good innovative technology, and definitely it will get us more and more patient to be screened, because people are more aware when they use these AI wearable devices. They are more self-aware about it. So if a wearable device tells them that during your sleep 3 or 4 times your breathing has stopped or your oxygen level has dropped, they will come to doctor and then get diagnosed for the OSA. So that way AI has been helping us, or may help us in future, about getting more and more patients to get the diagnosis of OSA. However, that is not a single most confirmatory test which I will tell. I will not say that patient right now to wear this device, and if it detects something then you will be diagnosed. At least at this stage I am not comfortable as a sleep specialist about trusting those devices. But however, in future maybe those devices will be more accurate and the values will be confirmed with the studies. That time maybe we will be diagnosing it only based on those AI wearable devices. Having said that, they can be combined together with the current modalities of the diagnosis. So it is not the exclusive AI tools, but we can collaborate with current traditional devices with the AI devices, and that will help us gain more and more diagnosis and avoidance of complication.
Yeah, I think future looks promising also. Now let's talk about CPAP also. So many patients actually struggle with it. So is there still a stigma about wearing it overnight?
Very true, because if we imagine for ourselves also, nobody would like to have a CPAP machine and sleep comfortably. It is very difficult for anyone to get adjusted to this, but it works in a wonderful way. We have seen drastic results in patients who had very severe OSA, AHI being very high, but with regular use of CPAP, it has come down and patient is doing fairly well. So that is a therapy of choice. There is definitely a stigma because even if at home, if you are using CPAP, of course there is trouble for the patient sleeping with the machine on continuously overnight. And if the patient is having traveling job, patient is going abroad or something, then carrying that machine, having that machine together always, all these troubles are there. But if we compare it with the complications which are going to be associated with OSA, then it definitely is worth taking the trouble, because there are some life-threatening complications that we all know of. OSA is not itself a disease, but it may cause many other complications like MI, cardiac arrest, there could be strokes and all these things. So avoiding these dreadful fatal complications, one should encourage to use the CPAP if required. Stigmatization, earlier there were stigmatization happens with all the devices, all the drugs, all the therapies. Now also when we prescribe inhalers, people say that will I get addicted to these inhalers, will I have to use this for life? So first and foremost questions which they ask us after prescribing CPAP therapy is that how long I will have to take it, whether I will have to take it lifelong, and is there any alternate way that I can use to avoid my OSA and other complications. So counseling the patient is the foremost in adhering to the compliance of the therapy, because if the patient himself or herself is not getting convinced about the therapy, then no other person from the family or anybody can motivate it. So first, letting the patient understand what exactly are the complications that are anticipated with the OSA and how it is going to negate those. If the patient gets convinced, then the adherence drastically improves. Now there are different newer machines, even the traditional ones are showing the compliance rate. So they actually shows that patient is using the CPAP machine for how long duration, for a month and all these things. So we get the entire compliance report in the machine also, and how it has improved the AHI, that also. So by showing this report to the patient, we many times try to reduce the stigma about the machine. So see, this is actually helping you, actually benefiting you. So rather than getting stigmatized about it, or rather than having the trouble sleeping with it, if you get accustomed to it and motivated to use it, you may not require it in future, and you may live a long life without any comorbidities. So that is how we as a clinician should try to motivate the patients and improve the compliance in those terms.
That sounds really exciting, doctor. So now finally, doctor, managing sleep apnea isn't just about prescribing a CPAP machine, right? So which other specialists need to be involved in for a comprehensive approach?
Yeah. So this actually involves two answers. One is that about the patient awareness. So if patient, even if he or she thinks that I may have sleep apnea, or patient is aware about the disease, patient doesn't know whom to go to. Many times they are not aware that which doctors they should go to first of all. So sleep medicine is still I will say, not in infancy but adolescence, and now the people are getting motivated to visit the pulmonologist, sleep medicine specialist about OSA. So it is not only the pulmonologist or sleep medicine specialist who will be managing the case of OSA. There are other stakeholders or other department also who are involved, and we also get them involved. First, whenever we are suspecting OSA, we do screening about that, and after doing the screening, we involve oro-maxillofacial surgeon. We also involve ENT people. We also, if sometimes required, we involve psychiatry for the sleep hygiene part of this thing. And we may also involve dietitian to reduce the obesity and all these things. So there are 4 or 5 departments which are involved in this. OSA not only involves CPAP, as you said, there could be sometimes surgical intervention required if there is upper airway obstruction. So there are surgeries like oropalato-pharyngoplasty, mandibular reduction surgeries. So if the patient or the candidate is eligible for those surgical intervention, OMFS surgeon or other surgery departments will get involved in that. So it is not only that you are diagnosed with sleep related disorders via sleep studies and you will be prescribed only CPAP therapy. Sometimes there could be corrective surgery which may help for long run, and sometimes there may not be. There could be only one treatment option of CPAP therapy. Having said that, we also have to negate the risk factors, because we may also have to take care of the hypertension which is involved with that. So medicine faculty may also be involved for the antihypertensives and everything. we may also have to treat the sleep hygiene, because sleep hygiene is also very important. If a patient is not having proper sleep hygiene and is having excessive daytime sleepiness and everything, so that also has to be taken care with the help of psychiatrist. And patient is morbidly obese, BMI being very high, 35 and 40 and above. So dietitian and proper exercise, everything, lifestyle modification is also a part of the management. So in such cases, we involve dietitian as well. So this is basically a multidisciplinary team that we usually involve for the management of obstructive sleep apnea. But first, patient should be aware about this, that you can visit all this and then finally get the diagnosis and get properly managed.
That's actually rightly mentioned that multidisciplinary approach is really important, and awareness is also a major thing that is there. So, Doctor, as we wrap up today's session, thank you so much for sharing your insights on this crucial topic and actually often underdiagnosed topic also. So, thank you so much for. It was such a pleasure talking to you today. And to our listeners, thank you so much for tuning into this episode. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the Medicine Apps platform. Medicine Apps platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay aware and take care.